Good morning, ladies and gentlemen. I'm Andrew Rennick, and I'm here on behalf of the Royal College of Physicians and Surgeons of Glasgow to introduce the Macewen Lecture. It's my great pleasure to introduce Ewen Harrison. He is one of the rare surgeons who seems to find more than 24 hours in the day and manages to do far more than us mere mortals seem to do within the working week. Which makes me quite envious. He is a graduate of Glasgow University, graduating in 1996. He did his basic surgical training in Glasgow and then transferred to Edinburgh, where he completed his higher surgical training before spending some time in Groningen and then being appointed as a HBB surgeon in Edinburgh. Along the way, he has amassed, I think it's 109 peer-reviewed publications. When I last looked on ResearchGate, that may have changed overnight. I'm not quite sure. He has also managed to set up a surgical statistics website. He leads the distance learning program in the University of Edinburgh and is also the lead director for Global Surge. I think he is obviously got far too much time on his hands, but my favourite fact of all is that he has a tortoise called Grandpa Joe that lives in a beer fridge over the winter. Ladies and gentlemen, I give you Ewen Harrison.
Thank you very much, Andrew, for that lovely, if slightly embarrassing introduction. Grandpa Joe was 8 weeks in the beer fridge this week and has recently come out and is looking better than ever. You'll all be pleased to hear. Thank you very much to the Association for this opportunity to speak. Thank you very much for the Glasgow College for the honour of being asked to give the William Macewen Honorary Lecture. 54,937 people died in Scotland in 2012, and this is how. This is affectionately known as the mortalogram. Each square is a disease area. The area of the rectangular square is proportional to the number of people who died, and the colours give you an idea of whether the incidence of that particular condition is rising or falling. So this is fun to make, it's useful to look at, and tells you something about disease in modern UK, if you like. But it doesn't tell you about the burden of disease in a society, the ongoing effects of disease. And it doesn't tell you anything about treatment needs. It doesn't tell you where you should target your intervention in order to benefit most greatly society. This is a different way of looking at similar data. This is specific for peptic ulcer disease. Each of these circles is a country, and the colour of the country relates to the Human Development Index. So that's a ranking from 1, Norway, all the way down to 180, 200, with Niger right at the bottom, based on a lot of different factors as to the resource and opportunities of individuals within that country. Along the bottom, along the x-axis, is years of life with a disability, and along the y-axis is years of life lost. So if you like, this is a graph of morbidity on the x-axis and mortality on the y-axis. And you can see that countries with the lowest Human Development Index, that peptic ulcer disease has a much greater effect on that population compared with those in higher HDI countries. This is Mavuto. Mavuto was 12 and was brought into hospital in the back of a Toyota Land Cruiser, which had been travelling around peripheral villages in Malawi for 24 hours before he was brought into the central hospital in Blantyre. Mavuto means trouble in Chichua, the local language, and Mavuto is in trouble because he's got, this is obvious, a perforation in his abdomen. So of the 7 billion people in the world at the moment, 5 don't have access to safe, timely and affordable surgery. And that's why surgery has been called the neglected stepchild of global health. Why is public health all about communicable diseases? Why is public health not about surgery? Back to our graph, the same one as before. If you compare this graph to a similar graph for malaria and put it on the same axes of morbidity on the x-axis and mortality on the y-axis, this is what you see. So we've now got, down in this bottom left-hand corner, everything that was spread out across that graph. So looking at single disease specialties in surgery and comparing them with the big famous diseases, if you like, of public health, like malaria, like HIV, like TB, they just don't appear on the radar. But if we look at all diseases treated by surgery, then the impact of those diseases is much greater than what we traditionally associate with global health. And so said in a slightly kind of flowery language, the impact of diseases treated by surgery is poorly captured by these traditional epidemiological frameworks that focus only on disease causes and not actually on the treatment needs of a given population. So, compared with Scotland in that same year, 51 million people died worldwide, and 17 million of those were from deaths that would be traditionally treated, from diseases that would be traditionally treated with surgical care, compared with only 3.8 million deaths from both malaria, TB, and HIV/AIDS taken together. So the Lancet Global Commission, I hope you've heard about, is one of a number of different strategies which are gaining traction in the last 18 months to try and put the specialty that we work in on the global health agenda, to try and help the patients that we treat on a day-to-day basis all over the world, not just in the hospitals that we are lucky enough to work in. But what is really obvious as soon as you start kind of taking an interest in this is that the data available worldwide is very poor and in many countries is non-existent. This is Frank Chapman. Frank Chapman was an ornithologist who lived in the US at the turn of the century. It was traditional at that time, around Christmas, to go on the Christmas Day bird hunt. So folk would go out and try and kill as many birds as possible. And Frank Chapman said, well, why not, rather than going out and killing the birds, why don't we go and count the birds, determine what species are present in our local environment, and bring all that data together in order to try and learn something about the area which he was passionate about, which was ornithology. So he and 26 of his friends went out on Christmas Day, 1900, and collected data on their bird species locally. And this is probably one of the first examples of crowdsourcing data, of asking citizen scientists, if you like, about the world, or in this case in the US, to go out to collect data and to pull it all together to try and answer some bigger question. This still happens today. 72,000 people contributed to the Christmas Day bird census in the US in 2013, and it is one of the, well, it is the largest ornithological projects worldwide. So it was with all this kind of background going on that three of us got together and thought, well, can we do something similar for data in surgery, and formed the Global Surge Collaborative. These research collaboratives have become quite common now, particularly in the UK, and they try to take a different approach to collaborative research. So traditionally, one might approach the head of a department, the professor, and say, would your department be able to contribute to this project? This is what we want to do. And the professor would look about and find some willing or otherwise younger individual and point to them and say, go and do this. This is a completely different approach to collaborative research, where we intentionally try to contact those at the very bottom of this pyramid of people. This is Barcelona pyramid competitions that are run every year. So we look for medical students and junior surgeons about the world, contact them and get them to go to their boss in a unit and say, look, there's this project going on, there's these folk who are, who want to get our unit involved in audit and interventional research. These collaborative programmes now exist geographically across the whole of the UK and across all surgical specialties. And just as an example, the medical students run a collaborative in surgery called StarSurge, and they've just collected data from 163 different hospitals across the country looking at the effect of obesity on outcomes after general surgery, with 10,000 patients collected over a 3-month period. So these are very powerful ways of gathering both observational and interventional data on a wide population basis. A lot of the success or failure of these programs comes down to the technology behind it and how easy is it to run these. Communication must be very straightforward. This is data for sub-Saharan Africa alone. 311 million, or 36% of the population, now have a mobile phone. You may have heard of this jump in technology where even in a village that doesn't have fixed electricity or certainly no fixed line telecommunications, individuals in that village can now have a mobile phone, and that penetration is rising exponentially. This is one of my favourite slides. It's not a map, it's a graph, and on the x-axis is latitude, and on the y-axis is longitude. And 1 billion tweets from Twitter contribute to this. Tweets that have been geotagged, tweets that when they were sent, the location of the individual is recorded, are put onto the graph, and then there's just a wee algorithm that makes them slightly brighter if they overlap. So there's no other information other than the tweets here. So you can see the UK, you can see the major conurbations of Europe, you can see road networks, you can see round about Greece, there's a lot of people in boats where it all becomes very hazy. You can see round about Scotland, there's nobody in a boat. And Twitter is also becoming very popular in low-resource countries. There is now good data supporting the massive upsurge in social media in general in South America, Africa, Southeast Asia. So we've run, we're into our 3rd project in this Global Surge Collaborative, and I'll just give you, I'll just tell you how the first one ran, just to give you an idea. It was an evaluation of emergency abdominal surgery to identify common modifiable best practices. What does that mean? Well, let's look at what everybody's doing around the world with emergency abdominal surgery and try to learn from each other and try to share good practice. That was quite an ambitious aim, as turns out. And the secondary aims, I think, are as important, or if not more important. Can a network of young surgeons and medical students collect bedside data internationally? What surgery is being done? What are the outcomes of that surgery? What indicators describe a good outcome? How do we determine, using these sort of methods, what success looks like? So any hospital could be involved, anywhere in the world. Anyone could be an investigator, and it wasn't limited to those with a medical degree. It could be a clinical officer, for instance, or someone with a nursing background. Any patient undergoing open emergency surgery defined as an incision which entered the peritoneal cavity could be included. So we looked at a number of outcome measures, some of them here: 24-hour mortality, 30-day mortality, major complication, surgical site infection rate, etc. The data set needs to be small and practical and deliverable. We had included some information on the patient themselves so that we could do some risk adjustment on the procedure itself for risk adjustment and for information, and the outcome measures on the right-hand side there. We translated the protocol into Chinese, Spanish, French, Arabic, Portuguese, put it on clinicaltrials.gov and published it. The translations were done by the International Federation of Medical Student Organizations. Who knew that such an organization existed? They are 1,500 really keen medical students from all over the world who have become a crucial part of this project. It was a 6-month period during which individuals only had to collect data for 2 weeks. So this particular project was a snapshot methodology. Individuals or teams could collect data on more than one occasion during that period of time, but it was important not to have any sort of barrier to inclusion by making it too difficult. The data collection is done online using a secure system that's supported by a mobile app which does not need a connection to the internet at any given time in order to be able to be used. So you can be offline, you can collect all your data, it's held encrypted on the phone, and then the next time you have access to the internet, the data is all uploaded. Again, this is essential if you're trying to collect data using technology in low resource settings. The software itself is produced free of charge by Vanderbilt University and takes quite a lot of technical support to set up and run, but is essentially, there's no cost to it. All the software that we use is open source. You haven't paid for any of it. Really importantly, so the individuals put their data in, and each of the individuals in that hospital can see each other's data, but they can immediately get it back out again, and they can immediately make graphs of the various outcome measures or generate reports for themselves. And quite a lot of the individuals just use this in order to snip out these graphs and put them into their own presentations so that they could compare their own local data with the worldwide data. It's not a black hole where individuals are asked to submit data and it disappears and you never see it again. It's a truly collaborative effort where the contribution of each individual is valued. The technology now is it's just advancing with such leaps and bounds. This was a kind of demonstrative small project that we did. So this open source software can query the database, so get the data out of the database automatically, can perform some sort of manipulation of that data, so make a graph or do a statistical analysis, and then put it out into a live Word document, so that, or PDF or web page or whatever, so that the next time somebody added a small piece of data to the database, all the numbers and the graphs in the document just automatically change. It supports photographs, it supports text messaging, questionnaires, and we're exploring the use of photography with a machine learning angle to see if we can help diagnose wound infection with a smartphone photograph. So at the last count, there was 2,700 individuals in 1,200 hospitals across 100 countries in this. The first study has just been published on Early View last week in the BGS and describes mortality after emergency abdominal surgery across these different countries. So there was data on 11,000 patients collected across the study period. I'm speaking elsewhere in this meeting, and some of the other results are being presented, and so just a kind of potpourri of some things. On the y-axis there is, again, Human Development Index with the poorest countries at the bottom and the richest countries at the top, and the different bars are the different types of surgery, or the indications for the surgery that are being performed. And that blue bar there is appendicitis. So whether you're in the poorest countries in the world or the richest countries in the world, appendicitis is taking up about 40% of the emergency abdominal surgery. Particularly in these in the low-resource countries, we had the best hospitals contributing data, and that's without doubt. And these data do not reflect district hospitals and smaller hospitals about the country. But we were surprised by this. Gallstones, as you might expect, is a Western or a high-income country disease, if you like, and trauma spread quite equally, trauma more predominantly in the lower-income countries. The headline result is that mortality is 3 times higher, despite quite aggressive risk adjustment in the poorest countries of the world compared with the highest countries of the world. Now, you might say, well, I mean, that just stands to reason. But these data haven't been available until now, and there has been no project which has used the same methodology to gather data from both high-income and low-income countries to try and actually put some bodens on the differences and the reasons that the differences might exist until now. Until recently, operative mortality, as in dying on the table or dying within 24 hours of surgery, was thought to be a sufficient measure of the contribution of surgery to that patient's outcome. And it's not. 24-hour mortality picks up about a quarter of those that have either a major complication or death from trauma, as you might expect. But for other disease areas, it doesn't really tell you much. It only picks up a handful of % of those patients that really do have a poor outcome after surgery. And this is difficult because 24-hour mortality is easy to collect, or easier to collect. If a patient is discharged from a hospital in a low-resource country at 14 days, then can we really be sure that we're going to get 30-day outcome measures? Probably not easily, but with the text messaging mobile phone technology, for instance, potentially. We looked for implementation and use for the World Health Organization surgical safety checklist, which I'm sure the vast majority of you will use in your hospital. And that was a really strong predictor of good outcome, not because the list itself, in all likelihood, is necessarily doing anything. It might be, but probably not. But it may be a measure of a hospital with a strong safety culture. And that was across low to middle to high income settings. And patient safety and the interventions that we can use to try and improve patient safety is likely to be very important. This is the last result slide, and it's not a result really, but so it was 1,100 individuals are collaborators on this publication. So in PubMed now, you have an authorship list. So the authorship is Global Surge alone, no names. And then there's a collaborator drop-down box now with 1,100 names in it. So each of these individuals has a PubMed citable publication. And that's really important that the whole purpose is to build research capacity and to inspire these young individuals to get involved in the research, not just to use them to further somebody in another country's career. Surgical site infection is the strongest outcome measure, has the strongest relationship with country resource. And that's the subject of the project that's ongoing at the moment. Anyone can still become involved. Data collection finishes in July. The Global Surge website has all the documentation and ethics documents and what you might need if you wish to set it up in your country, in your hospital rather. We currently have 4,000 patients involved and around 1,500 individuals collecting data. This is in preparation for a randomized controlled trial in surgical site infection, which the exploration of which has been funded by the MRC and Wellcome. And I hope to be able to come back and tell you more about that in the future. So those providing the clinical care about the world should be at the heart of the clinical research in those hospitals. It's important to try and engender a culture of day-to-day research, of day-to-day audit, of reflective practice. The technology out there now is affordable and powerful and can be used to deliver projects which, even just a few years ago were unthinkable. We can, if you like, kind of academics can provide clear protocols, can provide administrative support, can provide guidance, and to help the grassroots individuals in these countries come up with their own projects for things that are relevant to them. So Mavuto was very lucky. He was admitted to a hospital with very good healthcare resource for that part of the world. And he had an emergency laparotomy, had a resection of a piece of terminal ileum, and at least at day 10, when he was discharged home, appeared to have a good outcome from his surgery. This couldn't be done without everybody I mentioned contributing to this, and it truly is a collaborative project. William Macewen was a great surgeon and a great teacher, but also a great innovator, and I hope that he would approve of this project. Thank you very much.